is reaching near maximal levels at a very low ventilation. And the other problem, of course, is the mechanical perturbations and constraints that occur, again, across all chronic lung diseases. So trying to get a handle on this is what the challenge is during exercise. This just confirms that what I told you about, if you look at work rate over a measure of drive, the best we have is the tidal EMG relative to the maximal possible EMG. Okay, thank you very much, Doctor. When we look at, this is a good index of inspiratory neural drive, and you can see this is the situation in health. It's about 7% at rest, but as you get into disease, and this is only goal 1, 2, and 3, this intercept is raised and the slope begins to increase, so that at the peak of exercise, at a low work rate, drive is nearly 70% of the maximum possible. And this is, there's a gradation across the continuum of COPD severity. We have recent data on goal 3, 4, and they're vertically upwards, starting around 25 and hitting 70 with hardly at 40 watts. So that's when I'm looking at the exercise tests, I just want to get some handle on is the drive raised and by what amount. So a simplistic approach to interpretation would be to focus on the perceptual and ventilator responses to the standardized physiological task of exercise, usually an incremental test, and look at indices, crude indices, indirect indices of drive and the factors leading to the increased drive, look in some more detail at mechanics, and then look at the cardiovascular response, and we make the final decisions based on an integrated pattern. I'm not going to talk about cardiovascular responses today, and we'll focus on the first 3. Dyspnea is very important to measure, because if we don't really get a handle on the true limitation to exercise in a particular patient. And we do this using scales like the visual analog or Borg scales, which have been very carefully validated, highly reproducible and responsive to interventions, with at least a 30-year history of this sort of validation. And here we see VO2 versus breathing discomfort measured by the Borg category scale, and the patient has an elevated slope and stops at severe dyspnea at a much lower VO2. I also find it useful to look at ventilation as in the horizontal axis as a function of the Borg dyspnea scale. Invariably, if the patient has mechanical abnormalities such as increased resistive work, elastic work, or muscle weakness, then for a given ventilation, say of 50 liters per minute, dyspnea will be increased. And this contrasts to causes of dyspnea that are mainly a central drive without mechanics, where it just follows the line and it isn't elevated like that. So, for example, in obesity, this often, especially in non-morbid obesity, moderate obesity, is a factor of the increased metabolic cost of the physical task, which increases the VCO2, which increases the drive, and that means they're pushed up the slope, but you don't see this elevation. But for our purposes, we see that the ventilatory slope is invariably increased in disease. Now, the closest we can get to measuring the drive to breathe is the ventilatory output, the entire ventilatory output of the system, which we do regularly. This is VO2 over ventilation in health and disease, and you can see it's elevated. But using the mass balance equation, we can actually work out why in this particular person the ventilatory drive is increased. It could be that there's a metabolic increase in VCO2, which all is a direct relationship. It could be the dead space, the wasted ventilation or the dead space to tidal volume ratio, or it could be the arterial set point of CO2. And these really dictate the ventilation. And it's possible to see which of these are dominant in the patient with increased drive. So if drive is increased or ventilatory requirements are elevated, you can see that there's increased VCO2 exposure at the central chemoreceptor level. This could be increased physiological dead space. It could be early metabolic acidosis, and many of these people are deconditioned, so you get greater reliance on anaerobic metabolism. and a surge in ventilation reflecting this chemical drive of hydrogen ions seen directly at the central receptors. Critical arterial oxygen desaturation less than 60 millimeters of mercury will increase drive. And of course, if the system is loaded by increased resistive load due to airways disease, or if they're breathing close to TLC, we call it elastic load, that functionally weakens the muscles of breathing. So this means that to maintain ventilation, you need a higher drive. This comes from cortical centers rather than the chemical reflex centers in the medulla. But this is very important because most patients with lung disease do have intrinsic mechanical loading, either totally elastic in the interstitial lung disease population, and in the hyperinflated COPD, of course, you get the combination of both resistive and elastic loading. So, if we establish that ventilator requirements are increased at any given VO2 or work rate, then we look at these simple, which we measure anyway, the VO2 work rate efficiency slope, which is usually 10, dead on 10, amazingly consistent. If we're lucky, we'll identify an anaerobic threshold in people with more moderate disease who can get to higher VO2s. We're paying more and more attention to the ventilatory equivalent for VCO2, which is a measure of the ventilatory efficiency. Now, this is started by the cardiologist looking at pulmonary hypertension, but it looks like it may have a role also in diseases such as COPD and interstitial lung disease. And this is the normal pattern. We measure the intercept, we measure the nadir, and we can measure the slope also. The normal nadir would be 23 to 25, and you'll see that in patients with COPD, it can be in the 30s, mid-30s, or higher, particularly in milder to moderate disease where the ventilation isn't constrained. We can look at the saturation. We know if it's less than 88, that's going to drive ventilation. We can look at end-tidal CO2. Now, this is, of course, may not exactly reflect the arterial CO2. We have to bear that in mind. But you can identify people with alveolar hyperventilation where the end-tidal CO2 is low to start and remains low or decreases further during exercise. And we can actually measure the dead space, but that really requires arterialized CO2, not the end-tidal CO2. So, and it's a technique that requires a wee bit of familiarization, but actually it's very simple. And you get as close as we can to arterial CO2 without putting an arc line in. So this means you can measure the actual dead space using the Bohr equation. I'm just going to focus on one of those common drivers of high ventilation, and that's the VVCO2 slope. This is a group of people with mild disease, only gold 1 COPD, and you can see it's elevated at its nadir. It's 34.3, and the usual is less than 30. And this is an interesting phenomenon. The cardiologist will tell you, oh, there may be pulmonary hypertension here, because the main driver would be the high physiological dead space, areas within the lung that are poorly perfused relative to ventilation. Or there may be alterations in the set point. It turns out if you look carefully at this, the main driver seems to be the physiological dead space. So the VVCO2 gives you an indication of the pulmonary gas exchange abnormalities that are prevailing in your patient. And this is a study looking at the measured VEVCO2 versus arterial blood gas defined physiological dead space. And both in health and disease, you can see this strong relationship. So this is a window we get into the microvasculature, into the ventilation perfusion equilibrium of the respiratory system by simply looking at the VEVCO2. So let's go to mechanics now, and the obvious way to look at mechanics non-invasively is the flow volume loop, which has been nothing new about this. It's been run for decades, but I'm not sure it's sufficiently refined for people to make decisions based on it. It's usually qualitative or visual, but it does give you a lot of information. This is the tidal loop within the maximal capacity loop. This is, of course, from TLC to RV and exhalation and inspiration. And this is an inspiratory capacity maneuver, so after a quiet breath out, take a full breath into TLC. And the important components here are the inspiratory reserve volume, which tells us how close you're breathing to TLC. And this is the inspiratory capacity, the difference between TLC and end expiratory lung volume, the amount of air left in the lungs at the end of the quiet breath out. And I prefer the term ELV than FRC, because ELV is what we actually measure in the body box, for example. These are the volume time plots that we use, telling us the exact same thing. This is a full vital capacity maneuver to RV. This is tidal breathing, and this is the end expiratory lung volume. We ask the patient to take an inspiratory capacity and relax. And this tells you the distance, the reserve available for volume expansion, the IRV, equivalent to here. It also tells us the behavior of end expiratory lung volume if we do serial inspiratory capacities throughout exercise, because we know we've got fair sound information that TLC doesn't change, so any change in IC reflects the behavior of end expiratory lung volume. Now, Bruce Johnson was the first to attempt to add some quantification to the flow volume loop. And this is, and I agree with these, and we've looked at this in more than 100 patients, healthy and volunteers. Expiratory flow limitation in health doesn't exceed 25%. In other words, the tidal volume overlap with the maximal expiratory curve is less than 25%. And invariably in obstructive disease, it's greater than that. At the end of exercise, most people get to an end inspiratory lung volume, that's the end expiratory lung volume plus the tidal volume, of about 90% of the TLC, right at the top of the sigmoid-shaped pressure-volume relationship, where it's stiff and where the muscles are shortened and weakened. But in healthy individuals, they achieve this at the peak of exhaustive exercise at very high ventilations. In disease, as you'll see, they reach this point at much lower ventilations. The VTIC amazingly stops at 70%. The VT is 70% of the inspiratory capacity across health and disease. But if this reaches the 70% at a low work rate, you know there's a significant problem, because the VTIC is actually the inspiratory reserve volume, which means that they're breathing close to TLC and they're not going to be able to tolerate that for much. Then we look at tidal, expiratory and inspiratory flow limitation, and typically you would see that the maximal flows during the tidal breath in exercise is about 50 to 70% of the maximal inspiratory flow rate that can be generated in health. So we're getting there slowly but surely, and we're moving from the qualitative assessment of just looking at the pattern to getting some real data and translating that into mechanics. And you can do this sort of analysis on a patient with COPD. This is the resting tidal volume. There may be some degree of flow limitation because of the 100% overlap here. Red is the tidal breath during a point in exercise. You can see migration or shift to the left, indicating dynamic lung hyperinflation. We can see that the inspiratory reserve volume is diminishing. There's flow limitation that's worsened during exercise, but there seems to be some reserve left in the, a good bit of reserve of inspiratory flow generation. However, the mechanical constraints mitigated by flow limitation and breathing close to TLC don't allow for maximal inspiratory flow generation. And the maximal curve done at rest may underestimate the dynamic inspiratory flow reserves during exercise. But this, you see this and you know there's problems. You know that this is COPD, you know that there's dynamic hyperinflation, and you know that there's significant flow limitation and erosion of the inspiratory reserve volume at a low ventilation. Look at the breathing pattern, it gives you more information. This is the normal breathing pattern. First of all, dyspnea over VO2, and it's kind of exponential. It gets bad at the end generally. This is VO2 over ventilation. Again, it's curvilinear. This is the inspiratory capacity measures in health, and you can see it's steady so that the resting is not different from the peak. The IRV is derived, here's TLC, and that's the 0 point, and IRV is here at about 2.2, let's see. But during exercise, it gets smaller and smaller as tidal volume expands, and eventually they're reaching a threshold of about 0.5 liters below TLC, where really they can't go on much longer. And this is reflected by the behavior of tidal volume, this time as a function of ventilation. This is reversed hay plot. And you can see tidal volume expands nicely until it plateaus or flattens. Sometimes you can actually see a plateau there. And this is telling you that they're breathing close to their minimal IRV. And that's precisely the point that breathing frequency takes off. The drive to breathe is still there, but they can't respond by any further expansion of tidal volume. All that's left to them is an increased breathing frequency or tachypneic response at the end of exercise. So the beauty of this looking at breathing pattern tells us, and operating lung volumes, tells us where they are on this famous pressure-volume relationship of the relaxed respiratory system during a single breath from TLC to RV, when all the muscles are relaxed. We're designed to function within the linear part of the curve, and we avoid at all costs the both extremes. Obesity is down here, lung hyperinflation, people are breathing up here. As they expand tidal volume during exercise, represented here, you can see that even at the peak of exercise, they are within the linear part of the curve, where there is a steady, constant relationship between the drive to breathe, or the pressure generated, and the tidal volume response of the system. So in health, particularly in younger people, less than 35 years of age, end expiratory lung volume actually diminishes as expiratory muscles are recruited, and the inspiratory capacity actually increases. So that means they're further away from TLC. That's what's beautiful about the IC. It tells you where you're positioned on the curve and what sort of loads you're likely to face. So with that sort of background, let's look at some data. This is a 64-year-old lady. She's a 30-pack year smoking history. She admits to, and often they don't admit until you probe, to progressive exertional dyspnea over a year and a half. You examine her, there's nothing remarkable at all. Spirometry, I'll show you, and for some reason the chest x-ray was done by the family physician. So the simple question is, why is she symptomatic? And this doesn't help us. We've done the spirometry here. We see the scooping, where we invariably see that the tidal expiratory curves are abutting on the maximal curve, suggesting but not proving some degree of flow limitation. This patient would have fit into goal 1, it's less than 0.7 after 4 puffs of Ventolin or salbutamol, albuterol. And her FEV1 is 81% predicted. So why would she be breathless? Well, one, relying on spirometry alone, you miss the mechanical shifts that can occur, and you only uncover with additional tests of measuring the volumes. This is the predicted, and this is the patient's loop, as we've seen before. But TLC is up compared to normal. I should have put in the FRC, or the end expiratory lung volume, is also shifted to the left. The FRC is 138% predicted. Pulmonary gas exchange is fine, but a dead space was uncovered of 48%, which is high. The inspiratory capacity is 88% predicted, so still a fair distance from TLC, at least during resting quiet breathing. When you exercise her and use the approach we mentioned, first of all, we do confirm that she's quite breathless at this standardized work rate, and she stops exercise at very severe dyspnea before an age-matched control. So the question is, why is she breathless? Why is her Borg units up by 3 units? And the first hint, of course, is the ventilation over work rate. So at a given work rate of 60 watts per minute, she's breathing 11 liters per minute more. You can see that if you looked at this plot, you would have concluded that there is plenty of reserve, that she's not ventilatory limited. But what's much more important is what's happening at submaximal work rates compared to the healthy control. This gives you a handle on the actual dynamics rather than events at the peak of exercise. So you can see the breathing reserve at the 60 watt point is diminished in the patient compared to the healthy control. And this is important because it tells you there's some erosion of mechanical reserve. She was a part of the study, so apologies for showing group data, but hers was identical. Her ventilator requirements at this point in exercise were increased by 22 liters, that's close to peak, at peak actually. This is the VEVCO2 we talked about, up at rest and throughout exercise. And we actually measured dead space, which was elevated. So you can see the dead space in health versus disease, and it's elevated at rest and throughout exercise. So while in health there's very little difference between the alveolar ventilation and the minute ventilation, they're superimposed, this gap emerges here telling you about reduced alveolar ventilation, because, the difference is the dead space ventilation. We do breathing pattern, and we look at inspiratory capacity behavior every 2 minutes throughout exercise. This is health. In our patient, the IC diminishes with exercise. If we look at the IRV, compared to the healthy individual, it's reducing, it's an accelerated reduction of the inspiratory reserve volume, getting to a threshold where it's a minimal possible IRV, where the situation is such that they'll get extremely breathless and will soon have to stop. If you didn't have the information on the top two panels, you could just simply look at ventilation over VT and ventilation over frequency, not actually in this particular case, but you can see this plateau effect. So expansion of tidal volume and then no further possibility of expanding, reflecting proximity to the TLC and the shrunken IRV reserve. Now often the ventilatory, the breathing pattern response corresponds, it takes off at that point. In this particular patient, for some reason, it didn't. And again, you get the same information, but your more confirmatory information by looking at the flow volume loops, rest and exercise. And this is the inspiratory capacity maneuver in health. And this is our patient, everything shifted to the left. Flow limitation, hyperinflation. And now this patient has both expiratory and inspiratory flow limitation, and really limited opportunity to expand the tidal volume further. So filling up the loop, true critical mechanical constraints. And we've missed this if we just looked at the VE-MBV difference. Getting back to this again, remember we're designed, our muscles are designed to function maximally or optimally in the linear part of the curve. And this is her tidal, and this is her exercise, and we can see end expiratory lung volume increasing, and this migration towards TLC, look at the IRV difference. And when they're up there, much greater pressure, much greater effort, excuse me, and drive is required for the same tidal volume expansion. So that's why the simple measurements of breathing pattern, which you see the plateau in the tidal volume response, and the breathing close to TLC, tells us actually a great deal non-invasively about what the mechanical loads are in that particular patient. So we would interpret this simple study as severe dyspnea, but mild exercise limitation. She was 80% of the maximal, and she's only goal 1. We saw that at any given submaximal work rate, ventilation was increased, and this in part reflects the high VEVCO2. So already dead space, there's a vascular signal and dead space is up. We see her shallow breathing pattern mainly reflected in inability to expand tidal volume appropriately. And then we look at the flow volume loop in conjunction, and we see evidence of expiratory, inspiratory flow limitation. And we see this dynamic hyperinflation is amplifying these effects by causing an early attainment of a minimal IRV, and this translates into increased elastic work of breathing. So just now I think we understand why the patient was breathless and getting more breathless over the previous year, which if we just looked at spirometry alone, we'd miss these details. Then we'll go to someone with more advanced disease, 30-pack year smoking history. Despite triple therapy treatment, the patient can only walk 50 to 75 meters. It varies from day to day at a slow pace. MRC dyspnea score is 4. He's really cutting back on his physical activity levels and likely getting deconditioned. This is much more dramatic than the previous one. We see a total shift to the left with the large TLC. Inspiratory capacity is diminished, the difference between the TLC and end expiratory lung volume, at 72%. We don't know the critical cutoff for the IC, but there's nice studies which show that if it's less than 80% during resting quiet breathing, these people are very likely to be flow limited during spontaneous breathing. This is from work in Montreal and in Italy, which looked at the negative expiratory pressure technique to assess the presence of ventilatory limitation. And if the IC was less than 80%, there was evidence of flow limitation during quiet resting breathing. This tells you that patient is much more likely to hyperinflate during exercise as ventilation increases, simply because there isn't enough time between each breath to empty the lungs to the resting ELV, and you get this pulmonary gas trapping effect. And that is important for assessing bronchodilators. If their IC is perfectly normal and you give a strong bronchodilator, you're not going to gain much, because if the IC is normal, they're in the linear part of the curve. So maybe that's the reason why all these new clinical studies on dual bronchodilators compared to the constituent mono components aren't showing a great deal of improvement of the dual over the mono. But when you look and you see the people they've selected, they're not hyperinflated at rest, so you don't expect big effects on exercise endurance. Let's look at dyspnea. No question, it's up. Ventilation is up compared to the healthy control group. And the reason I'm showing you this is, as the disease advances and the mechanical problems become more and more severe, the ventilator response is blunted, because you saw the flow volume loop. So even though the drive to breathe is increasing like crazy, the ability for the ventilatory output to match that drive is diminishing. So often with the progress of disease, you don't see a marked increase in minute ventilation. This is dead space in control versus the patient progressive decline, and starting quite low, it's much worse at the peak of exercise. So this is done every 2 minutes throughout exercise. And it's been shown to be highly reproducible in 600 patients, very strong interclass correlation of 0.9, and also it's responsive to various interventions. Why did the patient stop? Well, by just looking at the IRV, they hit the minimal critical low IRV at a much earlier VO2, much lower VO2 than in health. We see the same pattern in the tidal volume response, the expansion with then curtailment. Often in individuals, this is group, actually is derived from group data, you can see an actual plateau. And the breathing frequency response is more typical here, so that at this point where tidal volume can't expand, there's a reliance on tachypnea to try and achieve the required ventilation, but it's only partially successful because increased breathing frequency functionally weakens the muscles more. And this is actual data from the readout, and you can see our patient here at rest and during exercise. You can see how the IC is shrinking, and you can see that's high-end mechanics, and this is displayed on the volume plot. There's hardly any room to breathe, basically. So this is available and in most of the metabolic carts, and it's an easy procedure to do, provided there's good familiarization with the testing at rest when the patient is sitting on the bicycle before you launch into the exercise. It's highly reproducible. And again, I'm not going to go into detail, but these are the responses. In health, plenty of reserve, a bit of flow limitation because these are an elderly healthy control in their mid-60s. But this is our patient with this continuous migration towards total flow limitation and actual ventilatory limitation. So in the second patient, severe dyspnea, and I should say significant exercise limitation, that's an error. The sub-maximal ventilation is still up. I didn't show you the data on the VVCO2, it was 34, and he reached an oxygen saturation after 2 minutes of exercise of 86%. The shallow breathing pattern and a rapid breathing pattern, and the constraints we've seen, critical restrictive constraints reaching a minimal IRV at a much lower work rate, which means that the respiratory muscles are under huge stress from elastic loading and from functional weakness. So again, we understand why that particular patient is more breathless. So in conclusion, I think this simple information complements the traditional approach to assessment of ventilatory limitation using the breathing reserve. And it gives you a lot more information on an individual basis of why your particular patient is breathless during activity. And the thing about it is that if you look across the continuum of the disease, we know that peak ventilation diminishes. This is a group of more than 400 people. These are quartiles going from mild obstruction to the worst obstruction. This is health, and this is dyspnea over ventilation, reaching these people in their late 60s, reaching a peak of 70 liters per minute. But you can see the shift fanning out so that these people with severe disease are nearly vertical dyspnea slopes at low ventilation. And if we go through the exercise that I've just mentioned, we can see that if you look across the stages of GOLD, 1 to 4, and we look at the VVCO2 in a population, this is 100 people, elderly people, you can see it's up even in the mild diseases. And the reason it doesn't continue to go up is because the VE is constrained because of mechanics. So the VVCO2 is a better measure of the physiological dead space in milder disease. In very advanced disease, it lets you down because of the blunted mechanical response. And similarly, we don't look carefully at breathing pattern, and I think it contains so much information. So that if you look at ventilation and against VT, against breathing frequency, and against dyspnea, and look at quartiles of disease from mild to severe, you can see the plateau effect occurring later and later as you get into the milder range. And this is remarkably reproducible. There's about 100 in each of these groups. And this, of course, corresponds with the point where the frequency response increases. You can see that the person with the most severe disease has a plateau at about 30 liters per minute. So you know that that person is reaching their minimal IRV at a very low ventilation compared to this individual with GOLD 1 COPD, or this group of individuals. And this is reflected in the frequency response pattern. In severe disease, it happens much earlier. But this is why I think this sort of assessment is relevant, is because if you look at dyspnea as a function of VTIC or inspiratory reserve volume, magically, no matter what the quartile you're dealing with, tidal volume expands nicely until it reaches 70% of the inspiratory capacity, and this is where the inflection occurs. And this is the point where dyspnea takes off. In other words, there's an accelerated rise in dyspnea once you hit this magical mechanical constraint where tidal volume expansion is no longer possible, even though the drive to breathe is increasing like crazy. So this neuromechanical dissociation is probably one of the reasons why dyspnea abruptly increases once you hit the threshold. So I'll leave it there, and thank you for your attention. I hope I've convinced you that a few extra measurements, which is already available to you on your plots, the readouts of your and exposure of your the plots, the 9 panels that are fashionable, that you get a lot more information about your patient, and that we learn a lot about their mechanical problem. Thank you very much indeed.